So my name is Arinze, Dr. Arinze Ikeme. I am a nephrologist and hospitalist in North Carolina. I'm also associate professor Campbell University, so I teach medical students. And today's discussion, I just wanted to discuss the use of intravenous fluids in the hospital. This discussion is for, medical students who are aspiring to be physicians, as well as other healthcare providers, new physicians, nurse practitioners, medical assistants, physician assistants, etc. So I'm hoping this will just be a run of how to use IV fluids in the hospital, and I'm hoping it will give you some background and some basics on which to decide on IV fluids and the amount. I'm going to be discussing the indications for IV fluids in the hospital. I'm going to talk about types of IV fluids, determination of the amount of fluids administered, importance of osmolarity and tonicity in the choice of IV fluids, very important, and how to titrate down and discontinue IV fluids. Again, while there are variations in practice, this would give you kind of a framework, at least an initial guide on how to proceed with IV fluids. So let's start with the indications of IV fluids. Some of the indications for IV fluids will be resuscitation in dehydration or all kinds of shock, whether it's hypovolemic shock, hemorrhagic shock, anaphylactic shock. Maintenance of hydration in patients who are unable to tolerate oral fluids, possibly after surgery, or people who can swallow. Management of electrolyte abnormalities like hyponatremia, hypernatremia, hypercalcemia. Management of acid-base disorders. IV fluids also come into play in especially metabolic acidosis, where you have to give some bicarb fluid. So let's talk about the fluids. There are two kinds of fluids you're going to encounter. You're going to have the crystalloids, which is very common, and also the colloids. I'm going to spend more time on crystalloids here, but we do have colloids, and we'll talk about them a bit. So for the crystalloids, they are IV fluids constituted by dissolving small molecules, solutes, like salt or glucose in sterile water. They are made up of water-soluble electrolytes like sodium chloride, sodium lactate, sodium and potassium chloride. These are water-soluble electrolytes. They are classified as either hypotonic, isotonic, or hypertonic, and we'll talk about what that means. And this is based on their osmolarity or solute composition compared to the plasma. Crystalloid fluids pass easily from the bloodstream into cells and tissues of the body after infusion. Example of the crystalloid fluids would include normal saline, which we are familiar with, 5% dextrose, or what we call D5W, lactated ring gas solution, plasma light, etc. You're going to also see things like D5 normal saline, D5 half normal saline, and the rest. So what about colloids? Colloids are IV fluids that contain large molecules. As opposed to the small molecules you see in crystalloids, colloids contain large molecules that are used to expand the plasma volume. The large molecules are too large to pass through capillary membranes, and so they linger in the intravascular space much longer than the crystalloid. The oncotic pressure exerted by these large molecules in the intravascular space pulls water from the interstitial space and expands the plasma volume much more. So it tends to be more effective in some way, but of course it's more expensive, and we don't use that commonly. Example would be IV albumin heater starch, which contains hydroxyethyl starch solution suspended in normal saline, pentastarch, etc. Even things like FFP, some of the cryoprecipitate, these are colloidal solutions, even though they are blood products. It can cause kidney damage, anaphylactic shock, or coagulopathies. This is one of the reasons we don't use it that commonly, but very commonly used in patients in the ICU who are third spacing with crystalloids or, unstable. This is just a picture showing some of the IV fluids, some of the concentrations of these IV fluid solutions, comparing it with each other. But I'm sure you see this in the hospitals. So how do you determine the amount of fluid you administer in adult patients? This is different from pediatrics, where you have to calculate mils per kilograms all the time. In adult inpatients, we tend to estimate, and we are maybe a little more liberal in the IV fluid administration. So it depends on the indication, whether you're resuscitating or you're maintaining IV fluids, or whether you're just correcting electrolyte abnormalities. That will determine the amount of fluid you administer. The estimated amount ideally should be the deficits plus the ongoing loss plus the maintenance. That means you have to accommodate the deficits before they come to the hospital, the ongoing loss if they are still having, for instance, diarrhea or vomiting or losing blood, and then the maintenance. So ideally, you should add these three together. The maintenance, adult daily fluid maintenance, is somewhere between 2 and 3 liters per day, or 0.03 times the weight in kilograms, while adjusting for activity level or the climate. Obviously, in hot weather, people's insensible water loss is higher. So on the average, it's about 85 to 125 mils per hour, which is about 100 mils per hour. If you add the ongoing loss plus the deficits, it can increase the rate to as high as 200 to 300 mils per hour for the first day at least, which may not be tolerable. That's a lot of fluid to give in a short time. Therefore, boluses, we depend on boluses initially when they present to handle some of those deficits. And then sometimes we also give boluses if there are ongoing losses or if the blood pressure drops. So for example, in sepsis, we suggest giving 30 mils per kilograms within the first 3 hours. So these are boluses, which is roughly about 2.25 liters within 3 hours in a 75 kilogram patient, approximately 750 mils an hour for 3 hours, which you can see is a lot, but sepsis calls for that. In septic shock, we go as high as 0.3 mils per kilograms per minute. That means we are giving about 1,300 mils within 1 hour for a 75 kilogram patient. Acute pancreatitis, we do 3 mils per kilograms per hour, which is about 200 mils per hour. So these are special cases where we modify. So it's not clear-cut deficits plus ongoing plus maintenance. We give boluses in certain situations, and then we begin to titrate down as the patient responds to treatment. Since maintenance is about 100 mils per hour, additional increase in rate depends on the estimated deficits and if there is ongoing loss, and typically somewhere between 150 to 250 mils per hour. More conservative fluid rate is adopted for patients with cardiomyopathies. This is very important, where you want to give lower rates of IV fluids and then give them additional little boluses of fluids as needed, so you don't overload them or put them into pulmonary edema. The next thing I'm going to talk about is what's the importance of osmolality and tonicity in IV fluid choices. So let's look at what this means exactly. I'm sure most of us did chemistry or physics during our basic sciences or pre-med. Osmolarity is a measure of the concentration of dissolved particles, which we call the osmoles, in a solution, expressed in millimoles per kilogram of solvent. So the unit is milliosmol per kilogram. So again, per kilogram of the solvent. The tonicity measures how this osmolarity affects the surrounding cell volume, dependent on both the osmolarity and the permeability of the cell membrane. So sometimes you hear us use osmolarity and tonicity interchangeably, but the difference, of course, is that quality of osmolarity. How does it affect the surrounding cells? And that's where the membrane comes into place, whether it's semi-permeable or impermeable. Plasma or serum osmolarity is the concentration of the dissolved particles in blood plasma, primarily determined by sodium, glucose, urea, and their corresponding anions. And the normal plasma osmolarity is 275 to 295 milliosmoles per kilogram. Some of us are familiar with the formula of serum osmolarity being 2 times sodium plus BUN divided by 2.8 plus glucose divided by 18 plus other substances like alcohol or mannitol in the system. And that's where, that's how you remember that the sodium, glucose, urea, and alcohol are contributors of serum osmolarity. There are other concepts like the other concept I'm going to try avoiding right now, just so it doesn't become complicated. Osmosis is the movement of water, of course, and other solvents through a semi-permeable membrane from an area of low solute concentration, which is the more dilute area with higher water content, to an area with higher solute concentration. And the major thing is to aim to use IV fluids as close to plasma osmolarity as possible, unless being treated for electrolyte abnormalities or acid-base disorders. This will prevent these fluid movements, which can definitely cause cell death, and we'll talk about that later. So what is the osmolarity of normal saline? Let's look a little bit at some of these fluids that we use commonly. What's the osmolarity of normal saline? Is it isotonic? Is it hypertonic, hypotonic? Why do we use normal saline very commonly? So what is the osmolarity? So a little bit of calculation, maths, and chemistry here, just to give us an idea how, why we use the concentration of normal saline, the 0.9% saline that we use in the hospital. So normal saline, which is 0.9% saline, has 0.9 grams of normal saline in 100 mils of solvent, which is water in this case, which means that 9 grams of normal saline is in 1,000 mils, which is a liter bag, usually how it's prepared. So the question is, how many osmoles is this 9 gram of normal saline in the 1 liter bag? So we'll look at that again. So 1 mole of normal saline has a molar mass of 58.5 grams. I know this is chemistry, but if you remember your periodic table, the molar mass for sodium is 23 grams and chloride is somewhere around 35.5 grams. And so 58.5 grams of normal saline is 1 mole of normal saline. And again, in a liter bag, we have 9 grams, and in 1 mole, we have 58.5 grams. So let's see how that compares. So 9 grams of normal saline will be 9 divided by 58.5 grams, which will give you 0.154 moles of normal saline. So due to the dissociation of the normal saline to 2 constituent ions, the sodium and the chloride, 1 mole of that normal saline will contribute 2 osmoles per liter. Again, I hope you're following me. 1 mole of normal saline contributes 2 osmoles per liter, and we are trying to figure out the osmolarity of normal saline. So 1 mole contributes 2 osmoles. So therefore, the 0.154 mole of normal saline that we calculated is 2 times 0.154, which is 0.308 osmoles, which is also 308 milliosmoles per kilogram of water. And that should be the osmolarity of normal saline, except, of course, due to the incomplete dissociation of the normal saline in solution. And this happens with every solute you dissolve in a solvent. It's not a complete dissociation. So the true osmolarity of normal saline is a little lower than that 308 milliosmoles per kilograms and around 286 milliosmoles per kilogram, making it isotonic to plasma osmolarity. Okay, let's look at the osmolarity of dextrose water. Okay, so dextrose water, D5, water has 5 grams of dextrose in 100 mils of solvent. That's why it's percent, 100 mils, which means that 50 grams of dextrose is in 1,000 mils, which is the liter bag. So the question is, how many osmoles of 50 grams is 50 grams of dextrose in solution? All right, so 1 mole of dextrose has a molar mass of 180 grams. And how did we calculate that? If you look at the structure of carbohydrates, it's C6H12O6. And if you calculate it based on the maths there, the total is 180 grams. So 180 grams of dextrose is 1 mole of dextrose. And remember, in our D5W, we have 50 grams, and 1 mole is 180 grams. So 50 grams of dextrose, not normal saline, sorry about that mistake. So 50 grams of dextrose will be 50 divided by 180 grams, which is 0.278 moles of dextrose. Dextrose, unlike normal saline, doesn't dissociate in solvents or in solution. So 1 mole of dextrose contributes 1 osmol per liter. Therefore, 0.278 moles of dextrose equates to 278 milliosmoles per kilograms, making it also isotonic to plasma osmolarity. Now, if in the bag, in the dextrose, in the 5% dextrose bag, it's pretty much isotonic. So, let's say isoosmolar rather. However, the isotonic is in parentheses because when you consider the semi-permeable membrane, you'll realize that dextrose is quickly metabolized after it diffuses into the cells, resulting in free water in plasma. Once the dextrose leaves the fluid, enters into the cells, gets metabolized, all you're left with is free water in plasma. So it becomes a hypotonic fluid once it's infused. So sometimes people will ask you whether dextrose D5 water is an isotonic solution or a hypotonic solution. The truth is it's an isosmolar solution in IV black, but it's a hypotonic fluid because once it's infused, because of the semi-permeable membrane, it diffuses, the dextrose diffuses into the cells, and you're left with a hypotonic fluid. So it is hypotonic once infused. So let's look at the effects of infusing either a hypotonic or hypertonic fluid. For hypertonic fluid, with prolonged infusion of a hypertonic fluid, there is movement of water molecules from the blood cells, which is hypotonic, to the plasma, leading to shrinkage of the cells and cell death. Like example, 3% saline. If you continue giving that, it can lead to shrinkage of cells in the blood and destruction, of course. For the hypotonic fluid, something similar happens. Prolonged infusion of hypotonic fluid will cause movement of water molecules from the plasma, which is now dilute and hypotonic, into the blood cells, which is more, which has more solute, leading to swelling of the cells and subsequent intravascular hemolysis. The cells would literally rupture and burst, and 0.5% normal saline can do that. It's a hypotonic fluid. And this is a diagram just trying to explain what we just talked about. So how do you choose IV fluids in specific conditions? Well, considering this osmolarity, again, I already said that the goal is to try to administer IV fluids that are isotonic or isosmolar with plasma, so that there will be less fluid changes. But in certain situations, we have to use certain kinds of fluid. For resuscitation in dehydration, bleeding, or shock, isotonic fluids like normal saline, lactated ringers are preferred. Acute hyponatremia, of course, you use hypotonic fluid. You're trying to dilute the sodium in the blood. So things like D5 water or half normal saline can be used. In situations of severe acute hyponatremia, especially symptomatic ones, we use hypertonic fluids like 3% saline. Maintenance fluid while patient is unable to eat, we tend to use dextrose-based fluid just to give them a little bit of calorie. And so we use D5 normal saline, D5 LR, D5 half normal saline if you want to reduce the sodium load, especially in cardiac patients. For acute hypercalcemia, we tend to use normal saline because we are trying to increase the renal calcium excretion, which needs a lot of sodium load in the distal tubule to increase the secretion. For intracranial bleeds with increased intracranial pressure, we use hypertonic fluid like 23.4% saline or mannitol, just to, pretty much cause that fluid movement and reduce the intracranial pressure. And avoid herniation. In severe non-gap metabolic acidosis, of course, we want to use some bicarb. So we either do D5 with 150 molar equivalents of bicarb, or we do half normal saline with 75 molar equivalents of bicarb. Again, the calculation is to make it as isotonic or isosmolar as possible. Then it's very important to titrate down and discontinue IV fluids when the needs, if the needs are met and you no longer need that. So you want to keep an eye on fluid administration over time. There was a trial done in 2016, many years ago, called the FACT trial, where they compared two approaches to IV fluids in patients with sepsis or ARDS. And it suggested that being conservative with your fluid strategy after the initial resuscitation resulted in increased number of ventilator-free days and decreased length of ICU stay compared with liberal fluid strategy. Again, it's just to let us know that IV fluids are not without risks, so you want to be very cautious while using them, and you want to stop them when you no longer need them. So I always advise you assess your patients daily to reduce IV fluid rates as needed and discontinue once the indication resolves. It's always best if they can drink their fluids, because that's always safer than IV fluids. So again, I hope this would help. It's not exhaustive, but I'm hoping that this will help clinicians, and especially those working in the hospital. It will guide them with the use of IV fluids in the hospital to prevent complications and understand the basis of the choices you make in both the amount and the kind of IV fluids that you use. Thank you.